Ischemic heart disease is a condition where myocardial oxygen supply is insufficient for demand. It most commonly results from atherosclerotic disease of epicardial coronary arteries. It remains the leading cause of death and disability in developed countries. Approximately 21 million individuals are affected in the United States. 3 to 4% of patients sustain myocardial infarction. Major risk factors include smoking, diabetes, obesity, and sedentary lifestyle. Prevalence is rising in low-income and emerging economies. South Asian men are particularly affected with higher risk burden. Myocardial oxygen demand depends on heart rate, contractility, and wall tension. Oxygen supply depends on coronary blood flow and oxygen carrying capacity. Coronary resistance is determined by epicardial, prearteriolar, and microvascular components. Ischemia occurs when myocardial oxygen supply falls below demand. Atherosclerotic plaque formation commonly occurs at sites of turbulent flow. A 50% diameter reduction limits flow during exertion. An 80% reduction may impair blood flow even at rest. Plaque rupture triggers platelet activation and thrombus formation. Collateral vessels may preserve perfusion in gradually progressive disease. Ischemia causes mechanical dysfunction such as hypokinesia or akinesia. Biochemical changes include lactate accumulation and adenosine triphosphate depletion. Electrical changes include T-wave inversion and ST segment abnormalities. Ischemia is reversible if it lasts less than 20 minutes. Irreversible myocardial necrosis occurs beyond 20 minutes. Patients may be asymptomatic with silent ischemia. Symptomatic presentations include angina, myocardial infarction, or heart failure. Stable angina presents as predictable chest discomfort on exertion. It is relieved by rest or nitroglycerin administration. Angina equivalents include dyspnea, nausea, and fatigue. Typical angina is described as substernal pressure radiating to the arm or jaw. Triggers include exertion, emotion, cold exposure, and heavy meals. Physical examination is often normal at baseline. Signs of atherosclerosis such as xanthomas or abnormal pulses may be present. Laboratory tests include lipid profile, glucose, and renal function. Electrocardiogram may be normal at rest but abnormal during ischemia. Exercise stress testing is used for diagnosis and risk stratification. A positive test shows ST depression greater than 0.1 millivolts. Coronary angiography visualizes coronary artery lumen obstruction. It is indicated in severe angina or diagnostic uncertainty. Computed tomography angiography and magnetic resonance imaging are non-invasive alternatives. Prognosis depends on age, left ventricular function, and severity of coronary disease. High-risk features include unstable angina, left ventricular dysfunction, and proximal coronary lesions. Management begins with patient education and risk factor modification. Smoking cessation, diet, exercise, and weight loss are essential. Blood pressure should be controlled below 130/80 millimeters of mercury. Statins are used to reduce low-density lipoprotein cholesterol. Antiplatelet therapy includes aspirin 75 to 325 milligrams daily. Beta blockers reduce heart rate and myocardial oxygen demand. Nitrates provide symptomatic relief of angina. Calcium channel blockers act as coronary vasodilators. Ranolazine and ivabradine are adjunct therapies in selected patients. Percutaneous coronary intervention involves balloon dilatation with stent placement. It improves angina but does not reduce mortality in stable disease. Coronary artery bypass grafting provides better outcomes in multivessel disease. It is especially beneficial in diabetes and left main disease. Clinical takeaway is that early recognition, risk factor control, and appropriate revascularization are key to reducing morbidity and mortality.